Thank you so much for taking the time at the very end of this long conference where I'm sure many of us are already starting to feel a little drained. I'll try to keep it entertaining, if nothing else. So we're going to be talking about AI in healthcare today, a little bit about the hype, a little bit about the challenges, and a little bit about where they meet in the world of real things that are happening. But we'll start with a positive piece of news, which is that we as individuals are living longer than we ever have before. And for you and me, that's great because we get to live longer and we get to keep our loved ones close to us for longer. But it does pose a little bit of a challenge to the healthcare system because the longer you get, the more likely you are to need some sort of healthcare. And this is already a challenge that you'll notice if you live in the Nordics and you read any of the newspapers, they will talk about a crisis in the healthcare sector. This is a large part of that crisis where we are needing to do more and more while not having a similar increase in resources. And unfortunately, as soon as in 2030, this is going to get even worse because the projections are that in 2030, here in Sweden, we need to be able to provide 25% more care than what we are providing today. We actually only have 75% of the personal resources that we have today because the generations have been getting smaller and smaller, and a lot of the people working in healthcare today are also approaching retirement age and will soon become patients instead of being the healthcare workers. So this is a really major challenge that I don't know if it's something that has been communicated to you, but every hospital and every region, which is kind of the homes of hospitals here in Sweden, they're very aware of this. And I think we're all agreed that this is a problem of the scope where we can't just keep saying to healthcare workers, how about you just do something a little faster, run a little faster, it'll be fine. This scope of problem, you can't solve by running faster. You actually have to do something differently. And AI is one of the reasons why, or one of the tools that we're trying to use to solve this major issue of a lot of production, not a lot of resources. And this is why there's so much interest in AI today. I'm sorry, yes? Oh, thank you. Can I make it go away? No. What do I do? Thank you. Perfect. Appreciate it. Yes. And why am I here to talk to you about this? Well, my name is Juulia Suvilehto. I am a data scientist at Sweden's largest hospital, the Sahlgrenska University Hospital. I'm actually one of the most longest serving data scientists in the Swedish public healthcare sector who don't work as a researcher associated with a hospital, but actually as a data scientist in a hospital. I'm also part of one of Sweden's hospital's largest teams of data scientists. We call our team AI Competence Center. And for the past 3 or so years, we've been working really hard to implement AI solutions into healthcare. I'm also a co-founder of the Swedish network for data scientists working in the public healthcare sector. So I've heard a lot of war stories, both from my hospital and from other hospitals, and that's what we'll be talking about today. So at work, I get to talk to a lot of clinicians, so people who talk to and treat patients. And my perception is that there's this really strongly bimodal distribution of opinions towards AI in the healthcare sector. We have the people up here to the right who are so bought in to AI as the solver of all possible problems that we might have in the healthcare sector. AI will take care of those pesky night shifts. AI will make so that we don't need as much people anymore. AI will reduce the human involvement in healthcare so much that we'll all be happily living after 2030, even after this major challenge has been realized. And these are the people you often see posting on LinkedIn or writing into newspaper, like letters to the editor sections, which is why this is the perspective I think dominates the popular discourse to a large degree. My personal experience is there's this other distribution tip as well. It's probably larger, I think, than the one that's in the hype end of the spectrum. And it's all of these hardworking professionals who are thinking, I haven't seen AI do anything for me yet. I haven't really heard of any type of AI solution that would actually help me in my work. I think this is a fad, and I think it's a fad that should go away so that I can continue doing my work. And I think, personally, an appropriate amount of optimism about AI is somewhere in the middle. So whenever I talk to clinicians, I'm trying to pull them in one direction or another. But I was thinking we'll go through the whole roller coaster today. We'll start from the what is there to be optimistic about, what is there to be pessimistic about, and then we'll end up somewhere in the middle about what is happening for reals. Did I again get the mouse pointer? It's gone away. Okay. So if you read academic papers, newspapers, you've surely seen headlines like this. AI is either meeting or exceeding clinician performance on any type of decision-making task available in the hospitals. More recently, there's been more and more headlines also about AI is being trialed in different kinds of hospitals. And if you see these headlines, that's pretty cool. That gives you a lot of reason to be hopeful about where we're headed. And in fact, personally, I think AI does have the potential to help us solve the three main challenges that our healthcare sector is facing today. And now I'm talking specifically about Swedish system, maybe about the Nordic single-payer system, but I believe these challenges exist elsewhere as well. The first one we already talked about. We need to be able to do more, and we need to be able to do more with less. So we need to increase the quantity of care that we provide. And there's any number of solutions that can help with optimizing the patient flow in the hospital, automating some of the processes that are happening currently very manually, making it easier to do a lot of the things that need to be done over and over and over again in the hospital. We also continuously want to work with quality of care. That is, we want to diagnose you quicker. We want to give you the right treatment quicker. We want you to recover better. And there is this enormous field of research. Academic research just looks at these problems. Can we use the data we already collect at hospitals today to give you a faster diagnosis, to give you a better choice of treatment? And then there's finally the bit that maybe doesn't get talked about enough, but it's also extremely important, and that is employee well-being. Statistics show that in Sweden, up to 50% of nurses and up to 20% of doctors are considering not changing jobs, changing professions, because they think their current workload is unsustainable. And they think that they have to work under a lot of ethical stress. They cannot give the care that they think they should be able to give their patients. And if we don't do something about this, it's not going to be 75% of personal resources in 2030. It's going to be way less than that, because these people are being trained often in the tech field and are leaving in quite large numbers. And one of the big drivers of employee dissatisfaction is that they feel like they have to spend too much time doing things that are not the thing that they went into healthcare to do. So they have to, for example, spend enormous amount of time for documentation, where you enter patient data into a system, you read patient data from a system, you search patient data in different systems. It's anywhere from a third to half of your work time just goes into looking at computer screen, trying to deal with that instead of being with the patient. Oh man, now I'm... Let's try to get that voice back. But for example, good news is documentation, that's largely automatable, or at least we could facilitate that much more. And often it needs a minimally smart system. It doesn't even need to be a large language model. We could do so much by just taking some easy peasy robotic process automation and taking data from one system to another and not asking for the doctor to painstakingly type the same thing in 3 different systems. So there's a lot of promise here, in my opinion. Where it might lean over to the hype side is when we start thinking, oh, the AI is probably so perfect that we will never make any mistakes ever again. It will know what's the right treatment for the right patient all the time. Or the AI will just erase the need of the healthcare personnel. Not that it will complement and help and support them, but it will take them away. We won't need those pesky humans anymore. That I don't think is necessarily real. And it's also we're veering towards the hype when we start saying, oh, these systems, they exist, they're ready. Whenever we could start using them, no lead time necessary. That's also not entirely realistic. But underneath all of this hype, there is really a bedrock of a lot of opportunity. Now let's have a show of hands. How many of you have been to any kind of healthcare provider and seen them use a system where you're like, that's probably an AI-powered system? 2 people, 3 people. How many of you have been to a healthcare provider and seen them use a computer system and you're like almost professionally insulted by bad that system looks? Exactly. So we're quite far from the reality of this good place. So let's shift over to the pessimism end and talk a little bit about why is this so challenging. Now, I've identified 4 kind of key areas of challenges. There are actually a lot more challenges, just like wrapped into a nice trench coat, but let's just talk about the trench coats. And the first one is, when we build these systems, we're often not solving the right problems. And this comes in kind of 2 different flavors. One flavor is most healthcare AI is built by researchers. And what do researchers get incentivized to do? Publish shiny, flashy papers that get a lot of citations. Do you get shiny, flashy papers by solving a really boring problem with a really boring technology, even if it has a huge impact? No, you want something new and flashy also for your problem and for your solution. And even for us who work inside the healthcare sector, we not infrequently get people coming to us, often from management, middle management, who come tell us, hey, can you give me a shot of that sweet, sweet AI like in my organization? And then we try to dig deeper and we go, what's the problem you want to solve with AI? And they go, no problem, just AI. And that's also not the path to a very useful tool being implemented in practice. So we're not necessarily great at picking what problems to solve with the technology that we have. We're also not always great at solving those problems so super well. A lot of the problems in healthcare are like legitimately really difficult mathematical problems where we might have poor signal to noise ratio. We might not have all the data that we need to make these predictions and build these models. Or we might not quite get the connection right. So, for example, a common problem that everybody would love to get a solution for is, of all the patients we discharge from the hospital, who is going to come back and need to be admitted again within a particular range of time, usually like a month? Because that means they weren't quite ready to be discharged yet. We could have given them better care if we kept them in a day or 2 longer. But that's an enormously difficult problem to solve because a lot of what makes you maybe have to come back happens after you leave the hospital, meaning we don't know anything about it. So all of the systems that I've seen that try to predict readmission tend to have a fairly poor performance because of this reason. We just don't know. even if we manage to build a good system somewhere, these systems travel really poorly. I don't have the exact numbers, but my hunch is that we're looking at maybe 10 to 20 percentage point decrease in the performance of a machine learning system when you move it from one hospital to another. These systems really, really do not generalize because they often learn some biased things about the specific patient population in here or the specific equipment that is being used in this specific hospital. This means that even if somebody struck gold, developed a really good model, we can't easily just stamp it all around. Finally, it's really difficult to kind of build these systems in a way that would engender trust in the healthcare professionals. Because as I was saying earlier, we're not trying to replace doctors or nurses or any kind of other healthcare professional. We're trying to help them. And in order for them to accept that help, they have to trust the system. But these systems are often built by people like me. I'm an engineer by background. So I'm like, system work, system good, user have system. And that's not really what you want either. The third major problem is all of the rules and regulations related to this space. Personally, I think like as a patient, regulate the hell out of this. I don't want any quack AI looking at my data. But as a person trying to make this happen, trying to get these tools into clinicians' hands, this is a really big issue because we don't really know what we're allowed to do and not. You'd think that we would, or at least our lawyers would. But every time we go to talk to our lawyers, they will not say, that sounds like a great plan, go ahead and do it. They will either say, abort mission, or it depends. And there is so much of the, it depends, where we just don't really know where the lines are. And the weird thing is these regulations and these rules, a lot of these laws are really new. Like they've come into effect 2 years ago, this year, that nobody knows because until we have court cases outlining this was on the wrong side of the law, this was on the right side of the law, all we really have is just interpretations of these regulations by different lawyers, which means that anything that we do technically is a risk. And if you are from Sweden, and if you know anything about public administration, it is that they don't like risk. So this is a really major challenge. For example, our lawyers would often want us to give a mathematical guarantee that there's zero risk of something. Really hard to give a mathematical guarantee of zero risk of anything, especially something that's really new and maybe doesn't work 100% perfect. We also, at the moment, as far as I can tell, are under the impression that we're not allowed to actually automate anything that relates to patient care. Well, we have to have a human in control. Not sure if that's exactly what the rules say, but that's kind of our interpretation of that. So that kind of limits the amount of things that we are able to make faster or automate away. And finally, this is a problem also on a bigger level, not just in my organization, because the kind of regulatory pathway that you need to go through in order to get to use AI in healthcare, to my understanding, it assumes that all kinds of processes are deterministic. Every time you put in something, you get the exact same end result. Can you think of any types of systems that might not be that? Yeah, there's a lot of AI systems that are not fully deterministic. And I don't think the regulatory authority knows how to test that. Or rather, they will say this system works not at all the moment it gives two slightly different answers to the exact same question. Finally, we as organizations are just like way not ready for this. I'm guessing many of you work in tech sector, so just try to come with me, think about an organization that's maybe never like built an app before, or at least like not built several apps. And now you go, can you build AI stuff, put it into production, monitor it, have all of these bits in place? It's a really big undertaking. So most hospitals in Sweden currently missing competence to do these things, processes to do these things, infrastructure to do these things. One of the fun legal things is we're not quite sure how much we're allowed to use the cloud. So at least where I work, we have everything on-prem, including training, compute, and inference, and data storage. All of these things are really massive bits to put in place if you're talking about enormous data masses. We're also really not there when it comes to data quality. If you worked in ML at all kinds of AI models, most AI models and all ML models build on data. If you don't have data, you don't have a model. If you have shit data, you have a shit model. Well, where I'm at, I think we have more than 100 separate databases, most of which are not linked in any reasonable way, except maybe by personal identification number that we thankfully have in Sweden. I think maybe like top 10 systems maybe talk to each other or are kind of like reasonably primary key linked. Trying to build some kind of a system that takes into account data from all of these different things that we have in-house is just, it's a lot. We're also not quite there yet when it comes to our users and taking our users along on this journey. I mentioned earlier that trust is really important in healthcare. And imagine being someone who you actually know that your decisions could mean life or death to someone. And then somebody comes in and says, here's a good tool, use it. No training, no change management, no explanations, no nothing. That's not too far from where we are right now. We're not really engaging our end users in the ways that we should be because we don't have the competence or the in-house kind of processes for how is this supposed to happen. So we're just generally not quite there yet. So now we've gone through the optimism. There is a lot of promise in this. I promise, that's my view at least. And the challenges, which they exist and they're quite major. So what does this mean in practice for us? Well, we're working really hard to connect the dots, and this is work that's going around Sweden in my organization, but in many others as well. We're trying to hire the right kinds of competence that will then hopefully help change our organizations into something that understands that, yes, in order to have a machine learning model in production means that we need to also be able to serve that model, for example. Also to build the infrastructure, like I said, many places now are saying we want to have stuff on-prem. Some brave regions have said, we'll do cloud and we'll see how that goes. There's a lot of work happening in the legal space, both within organizations, but also kind of like collaborations in Sweden, because I told you this is not a question that just we have. Like everybody's like, what is okay and what is not okay? So there's a lot of national discussions that are happening about what can we together agree upon, what is the kind of right interpretation of these laws and regulations. I'm hoping that all of this, or I'm seeing that all of this is helping us slowly get better at picking the right problems. If you remember, we're maybe historically not doing that, but understanding the landscape and what we're allowed to do will help us better pick those problems where we can actually give real concrete benefits in a shortest possible amount of time. And finally, there's this very slowly emerging best practice around how do we build, maintain, manage these kinds of systems in a healthcare setting, which again is very much not a technical business to begin with. So like I mentioned, we've started a network. That's what data scientists working in the Swedish public healthcare sector. We started out as just a couple of people about a year ago. Now we're already up to 40 members. And the good thing about working in the public sector is that we are all paid by the same person, which is all of the taxpayers there in the audience, you. So we're actually able to very openly share our struggles, our successes, and so on and so forth, to try to share the best practice so that not everybody has to learn the hard way that this is a problem that is not solvable by the data that we have gathered, for example. Let's make it a little bit more concrete. Some solutions that are actually already being used in hospital that I would classify as AI. We're doing speech to text where I work. So historically, a doctor would like dictate into a little microphone, and then it would get taped, and the tape would get sent to somewhere completely different, where a medical secretary would like sit down and write it up into a computer when they had time. Now the doctors are speaking into a microphone, and it's immediately getting translated onto their screen into text. They can edit it on the spot, and it gets added into the patient record immediately, which speeds up the kind of information transfer between different units enormously. We're using, again, in my hospital, we're using and testing and implementing different commercially available diagnostic tools, often related to radiology. So different kinds of pictures we take of your body that will either help the doctor, so kind of like show the doctor, look here and look here, that looks a little weird, or maybe help prioritize, like, hey, look at this picture first, this looks really alarming. And we're, like everybody else, we're trying to figure out where can we use large language models, and we've started testing it in things that are as far from patients as possible, because we're pretty sure we're not allowed to use them on patients right now, or at least not without a very extensive regulatory process. But for example, there's recently a project where like 3 different hospitals wanted to harmonize how do we handle blood samples of 1 million different types, and each of the 3 hospitals had their own little routine documents about this is what we do. So we built them a very simple wrapper around a large language model that would have a system prompt that said, like, compare these documents that you're given, helpfully highlight what's like common and what's different, and then a human does the final decision of which version we keep. So this is all things that are being done today. Not maybe super flashy in the grand scheme of things, but already very helpful. What I think we'll be seeing soon, meaning soon as in hospital soon, 2 to 5 years maybe, that's like a really short timeline in the hospital world. I'm very hopeful that we'll start seeing solutions within like scheduling and planning that may be homegrown or they may be bought. But you, like, if you have not worked in healthcare, you wouldn't believe how much time is put just for like scheduling shifts or making sure that we have booked the right operating room and the right equipment and the right personnel for this operation, and then for the next operation, then for the next operation. This is not something that an intern is doing. This is usually like one of the leading nurses or doctors in the clinic that is doing this scheduling, and is taking up enormous amounts of time. And it's not exactly anybody's favorite activity. So I'm hoping the technology exists essentially. It's just a matter of getting it implemented and getting it into practice. I think also we will be seeing hospitals soon, much more kind of novel diagnostic devices. I think there's been a couple of talks about, for example, using olfaction in diagnosis here. That might be one. Or there's a lot of academic research going on about mobile phones, and can we use like the camera in the mobile phone to diagnose something, or voice recordings taken by the mobile phone. So all these kinds of new systems for diagnosing you better. And I think there also, like, a lot of this technology already exists. It's just the process from having a proof of concept that you've shown works in an academic paper to getting it implemented into a hospital is a very long process. So I think we have a lot of really promising solutions kind of at different stages of this pipeline, and I'm hoping that drip, 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 we'll be seeing more and more of that in the actual clinical practice. And finally, for the soon sector, I personally am very hopeful that we will see more and more ambient scribes in healthcare. Ambient scribe is the type of system where you have a little microphone that listens to the conversation between the patient and the doctor, and instead of the first having the conversation and then the doctor turns away to the computer and then stops typing. I don't know if you've seen doctors type, they type often like this. Instead, there's this system that often builds on large language models that will, from the recording, first speech to text, and then from the text extract the things that the doctor would want to put into the electronic health record, and gives a draft of this is probably what you would want to write about this. This is the symptoms the patient mentioned. And then the doctor can kind of just oversee it, fix anything that looks weird, and then add it into the system. These systems exist already. They're already being sold and tested in different places. I'm thinking that maybe it'll take a couple more generations before they're at the level of quality that we want them to be. For example, I had very early in the presentation, there was this newspaper clipping about like, oh, there's a hospital in Taiwan that's using like nurse co-pilots and pharmacist co-pilots. Yes, they're using it, but the same piece also said that nurses rated out 3 out of 5 stars. And I would not get into an Uber that's 3 out of 5 stars. I'm not sure if I want my medical data to be handled by a solution that's average rated 3 out of 5 stars. But I do think there is, I think these obstacles are something that we can overcome. So I'm hoping that within a couple of generations, these systems will be good enough to have like widespread adoption. And these might be actually, up until the scheduling part, this was all kind of boring behind the scenes stuff that you as a patient probably will never see. Depending on what kinds of diagnostics you're going to get, you might not see those either because they tend to be very specific solutions for very specific problems. So I think this, if we get to the ambient scribe point in time, I think that's the first time you will start noticing that all of these things are happening. So that's a good thing to keep in mind. A lot of things are happening kind of bubbling under. Not all of it is coming to the surface just yet. And then if we look a little bit further ahead, we say 5 to 10 years. My prediction is that we will finally reach at least the initial stages of what everybody has been saying will happen tomorrow, which is we'll start to be able to give more individualized treatments. We already do this with particular kinds of cancer, where they're able to look at your genome or sequence the cancer and go, this is the type of treatment that works with exactly your type of cancer. But for most conditions, not a clinician, but my understanding is you kind of have a list of like, try first this, then try this, then try this. And if, let's say if you get diagnosed with depression, and your treatment is like the 5th on the list, it takes like whatever 3-4 months for the treatment effect to show. So that's a really long time you'll be without a functioning treatment for you. Whereas with data, with the magic of machine learning and clinical knowledge, we might be able to better say, usually we start with this one, but because you have these characteristics, we think we'll start with something else. We think that has a higher chance of working for you. I know this is the holy grail that all the clinicians are waiting for. We don't necessarily always have the data or the research for that yet. So it's going to take a while, but I know that there's a lot of enormous amounts of research going into this space, which makes me very hopeful that at least some of these solutions we'll see in the 5 to 10 year time span. And other type of solutions that we'll see a little later, but I'm pretty sure we'll see, is different kinds of individualized risk scoring, where either you're in the hospital and we have a system that kind of continuously monitors how are you doing. Do we think it's likely that you will be doing a lot worse very soon, in which case we will alert the doctors, nurses, and other professionals to come take a look at you before you get worse. Or it might be in terms of like population screening, like maybe you don't get called in to get a population level screening every 3rd year, you get called every 5th year because you have a very low risk score, which would allow us as a system to focus our resources much better, which would again help us do more with less. And I think the technique to do this actually already exists. I know that places in North America are already running these types of risk score things, but here in Europe, legislation is making it really difficult at the moment to implement. Or we're not quite sure how dark or light gray this area is. So to get to the point where we actually have a system and we dare to implement it, I think might take some time. I'm hopeful it will come sooner, but who knows? And finally, I'm personally very hopeful that we will see a day when most of the documentation and data input in the hospital will be done by some kind of automated system, a robot, an ML model instead of a really highly educated human who hates every second of their typing. And depending a little bit on how the technology develops, maybe 10 years, within 10 years, we could be there. But it's a little difficult to say because there's, again, both regulatory and technical unknowns on this path. So there we essentially have it. We've talked about how there is legit a lot of promise for AI in healthcare. Sometimes people veer a little bit too much to the hype side, but the promise is there. We've talked about a lot of the challenges. I think the people whose opinion falls somewhere here, they probably see at least one of these challenges or maybe more, and they think that these are challenges that we maybe cannot overcome. And we've talked about kind of the middle of the road where we start with something very pedestrian, but still very useful, and we build up our capabilities and our organizations towards the flashier implementations that, no, not going to come next year, but within your lifetimes, hopefully. Thank you very much.